Thank you, Professor Humphreys and Professor White, and thank you all for being here. I don't think we would get a crowd this good at 6 o'clock in the evening in Boston, so I'm really touched. So let's begin. What does it mean to be dead, and why should it matter? So what does it mean to be dead? Let me reflect a little bit on one of my favorite movies, The Wizard of Oz. And you might remember the part near the beginning of the movie when the house falls on the Wicked Witch of the West and she's crushed underneath it. And the Munchkins are delighted, but also a little bit worried. They're not really sure that she's dead. And so they come up to Dorothy and they say, but we've got to verify it legally, that she is morally, legally, ethically, physically, spiritually, most reliably, undeniably dead. And the coroner comes up and says that he's thoroughly examined her, and she's not only merely dead, she's really most sincerely dead. And I think today the public is asking us in the medical profession to be in the role of the coroner and to really be able to know when patients are most sincerely dead. And why is that then? Why does it matter? Well, it matters because of organ donation. And I realize you're all not necessarily a medical audience, but I'm going to try to walk you through some of the particulars related to organ donation and the definition of death. So we have two pathways. Let's see, that's the microphone. I thought I might have a little laser thing, but maybe not. No problem. So we have two pathways to organ donation. So if you follow down the left-hand side, this is the brain death pathway. And here we determine that the patient is dead based on the irreversible loss of all of their brain function. And then their organs are removed while their hearts are still beating. This is the preferred way because by taking out the organs while the hearts are beating, they're still getting blood, and so the organs are in the best possible shape. Down the right-hand side is the donation after circulatory death pathway. And here the patient is declared dead on the basis of the irreversible loss of circulatory function, and organs are removed 2 to 5 minutes after cardiac arrest. This is less preferred because the organs have gone for 2 to 5 minutes without any blood flow, so the quality is not as good, and actually in many cases only the kidneys can be procured, not other organs like heart, lung, liver, etc. All right, so both of these you'll notice have at the top, is the patient dead? That's the starting place. Now, why is that? That's because there is a principle in organ donation which has been called the dead donor rule. It's not actually a law anywhere, but it's sort of a principle that says that vital organs for transplantation may only be procured from patients who are dead. Or if we phrase the rule in a different way, physicians may not cause death when procuring vital organs for transplantation. So this is sort of underlying all of the ethics that we bring to organ transplantation. Now, for most of history, determining when somebody dead wasn't all that important. I mean, we knew that they were dead when they were cold, blue, and stiff. But all of that changed in 1968 when Christian Barnard in Cape Town performed the first heart transplant. And as he was coming out of the operating room and meeting the press, one of the first questions that he wasn't really prepared for were people from the media saying, well, you know, was the patient dead before you took out the heart? Or if he wasn't dead, then did you kill him? And he didn't really have an answer for that. And fortunately, Dr. Barnard's brother was a little bit more fluent with the press and went on and kind of, you know, said something to satisfy them. But it made a deep impression. And people were very concerned. Like, how do you take a heart out of somebody if you don't know what their status is? And so later that year, Henry Beecher, who was an anesthesiologist at Massachusetts General Hospital, saw a real career opportunity. You know, this heart thing is getting off the ground and somebody needs some guidance, so what better place than Harvard to do it? So they got together and they published this paper. And you can already see some of the roots of the problems here. You'll notice that the title of the paper is A Definition of Irreversible Coma. There's no mention of death in there. It's down in the subtitle that they talk about examining a definition of brain death. But in fact, there's never any explicit relationship between these two. And indeed, that bridge has never been built. And in fact, what we see here is actually wrong, is that irreversible coma is not brain death. There's many patients who are in an irreversible coma, patients in a persistent vegetative state. They're not brain dead. So the paper's got a lot of problems. And this goes on for another 10 years or so. And then in 1981, we developed the Uniform Determination of Death Act, which says, this is the United States brain death law. So an individual who has sustained either irreversible cessation of circulatory and respiratory functions, or irreversible cessations of all functions of the entire brain, including the brain stem, is dead. And a determination of death must be made in accordance with accepted medical standards. So let's follow this through. First, I'd like to examine the left-hand pathway here, the brain death pathway, and look at whether we have good reason to believe these patients are dead. And then we'll talk about the right-hand pathway, and then we'll talk about where to go from here. So in terms of the brain death pathway, an individual who has sustained irreversible cessation of all functions of the entire brain, including the brain stem, is dead. Notice how emphatic and redundant this is. Irreversible cessation, all functions, entire brain. By the way, don't forget the brain stem. It's pretty emphatic. But as soon as the law was published, people recognized that there were problems, that many patients who meet all brain death criteria actually retain selected brain functions. Everybody knew this, that many of these patients had fluid and electrolyte homeostasis through hormonal secretion. They had temperature regulation, which is a brain function. They also, many of them had brain wave activity, EEG activity, and when they went to the operating room to have their organs procured, their heart rate would go up, their blood pressure go up when skin incision was made. So there were a lot of brain functions that were there, and everybody knew that. And furthermore, the brain death examination explored only a limited number of the possible testable functions. So for example, when we diagnose brain death, we look very carefully to see if the pupils respond to light. You know, we get a magnifying glass and we look really carefully. But you know, you can live just fine if your pupils don't respond to light. But the things that actually really do matter to life, like, you know, having this regulated secretion of hormones, regulating your temperature, et cetera, no one even looked for those things. So a real problem. And along to the rescue came Professor Jim Burnett, professor of neurology at Dartmouth, then and now, with really an idea that rescued this law. So he wrote this paper. I think it's one of the most important papers that's been published around definitions of death and brain death. This was in 1981, and it's famous, I think, both for what it does very, very well and also for where it fails. Now, I'm going to be mentioning Burnett a bunch in my talk. He's kind of my arch enemy here in this debate. He always has been, and you know, so I'll be not making fun of him, but I mean arguing against him as we go through this. It's a wonderful man and very bright, but I do disagree with him on almost everything. So what he did really well in this paper was he said, we define death as the permanent cessation of functioning of the organism as a whole. I think this is really one of the best definitions, maybe the best definition that's been put forward. He also said that death is considered a biological occurrence that is not unique to humans, that it should, whatever definition we have, it should cross the biological spectrum, apply to all kinds of organisms. And he was pushing back here against those who wanted to argue that the death of a person is somehow different, related to loss of consciousness or personhood, et cetera. And then finally, he said that death is an event. It's not a process. Here pushing back against those who said that the dividing lines between life and death are kind of fuzzy. All right. Let me expand a little bit upon his ideas, because his ideas actually go back hundreds of years. They go back to the notion that life and death can be understood and defined in terms of thermodynamic concepts, that living organisms are distinguished from the inanimate world by their use of energy-consuming processes to oppose entropic forces that seek to cause chaos and maintain the balance that's known as homeostasis. So these ideas were first articulated by Claude Bernard in France in the 1800s. In 1930, Walter Cannon at Harvard coined the term homeostasis. This has a long history in terms of how we understand what differentiates the living from the not living. And as Bernat put it, life is the integrated functioning of the organism as a whole. So if I want to present this a little bit simplistically, but hopefully make it a little more clear, imagine that this yellow circle here represents a living organism. Might be an amoeba, might be a tree, might be a dog, might be a human, okay? And this living organism is alive as long as these entropic forces, which are seeking to pull it apart, are perfectly balanced by these homeostatic forces that are holding it together. And as long as there's this balance between these two forces, this is a living organism. But when those forces that are opposing entropy are no longer strong enough, then chaos takes over, and now this becomes inanimate. And where this happens is essentially at a moment in time. We may not be able to know exactly when that moment is, when the organism passes this point of no return, so that no matter how much you try, you can't possibly pull this organization back together. I would say in human beings that are typically dying, it's probably somewhere around 15 minutes after the heart stops, where there's no way that you could bring this organism back to a state of equilibrium. So on this part, I think Jim Bernat got it wonderfully correct, and this has been a major contribution. But there's a part he got terribly wrong. And this is where he wrote, "The criterion for cessation of the functioning of the organism as a whole is permanent loss of functioning of the entire brain. This criterion is perfectly correlated with the permanent cessation of functioning of the organism as a whole, because the brain is necessary for the functioning of the organism as a whole. And as evidence," he said, "destruction of the brain produces apnea, that is a loss of respiration, and generalized vasodilatation, that is shock. In all cases, despite the most aggressive support, the adult heart will stop within 1 week and that of the child within 2 weeks." So what he's postulating here is that the brain is kind of command central for the body. That when the brain's functioning, everything's organized, but when the brain is gone, the body disintegrates. It just falls apart. The problem is, this is no longer true. Brain-dead patients can retain integrated functions. They can live for years. Now, why did he get it wrong? Well, it might have been true back then, and let me explain what I mean. I'd like you to think about an analogy to brain death, which is high cervical quadriplegia. And the example I use in my country is that of Christopher Reeve, the actor who played Superman, had a terrible accident horseback riding and had a high cervical cord injury. He lived for a number of years, but required a ventilator to assist him to breathe. Died a few years ago. Now, it's an analogy to brain death because in both cases, the brain is separated from the body. And what happens is that when the body loses influence from the brain, it kind of goes nuts. It's not really sure it knows how to function without the brain. And so you get these wild swings in heart rate and blood pressure, and most often, without really, really good intensive care, this can lead to death. But if you can get the patient through a week or two, they stabilize. And in both brain death and high cord injury, they can go on to live for years. And so what this means is that the brain is not command central for the body. That in fact, after this sort of tumultuous moments or weeks, the body gets used to not having a brain and can go on and live just fine. Now, in fact, our ICUs are not filled with brain-dead patients. Now, why is that? I mean, we could keep them there for years if we wanted to, but it's pointless. And in fact, brain death kind of functions as a legal definition of futility in the United States and in Australia, so that once we diagnose this, we have no obligation to keep these patients alive, but we could if we wanted to. And so it sort of shows the problems with this justification for brain death. So just to summarize here what's been said, what is clear from a comparison with spinal cord injury is that the mainstream assertion that brain death represents the biological death of the human organism as a whole is untenable. And a few years ago, we had a President's Commission look at this, and they agreed. If being alive as a biological organism requires being a whole that is more than the mere sum of its parts, then it would be difficult to deny that the body of a patient with total brain failure can still be alive, at least in some cases. So I think this is pretty much settled at this point, and I really think from a scientific point of view, there's no debate here that brain death is not the loss of the integrated functioning of the organism as a whole. Okay, let me say a few words now about our other pathway of organ donation, the DCD, or donation after circulatory death pathway. Let me tell you just a little bit about DCD, because probably most of you are not familiar with it. So here's how it goes. Let's say we have an unfortunate person in the ICU where we realize that they're not going to survive with good quality of life, and with the family we make a decision to withdraw life support. Now, in order for them to be a DCD donor, first of all, we have to expect that they're going to die within 60 minutes of us taking them off the ventilator. Why is that? Because if they have a lingering death, the organs will slowly be exposed to low levels of oxygen and they won't be any good. So they need to die fairly quickly. Then, if they look like they're a good candidate, we take them to the operating room and we take them off the ventilator and we wait. So we're watching to see if they die in 60 seconds. And by die, what do I mean? We're looking for their heart to stop, for them to become pulseless. And at the moment they become pulseless, a stopwatch starts. And at that point, in my hospital, they're moved into another operating room, and we're watching the stopwatch. And after their heart has stopped, after they've been pulseless for 5 minutes, the stopwatch is clicked again, they are declared dead, and surgical incision is made for organ recovery. So that's how DCD works. Are those patients dead? Well, everyone agrees that at least some, probably most DCD donors could be successfully resuscitated after 2 to 5 minutes of pulselessness. Hence, it's not irreversible. I mean, every day on the streets of our cities, paramedics are going out, they're finding patients who have collapsed with MIs and things. They've been pulseless for longer periods of time. Many of them are resuscitated and do just fine. So it's pretty clear that at 5 minutes, the loss of circulatory function is not irreversible. As Jim Burnett himself wrote some time ago, the DCD donor is dying but is not yet dead after only 5 minutes of asystole. But since then, he's changed his mind because he thinks that irreversibility is not the important thing. And he's argued that permanence should legally substitute for irreversibility. Now, what does he mean by permanence? So imagine, we're in the operating room and the heart stops and the patient's pulseless. And we're watching 5 minutes, 10 minutes, 15 minutes. Somewhere out here, the loss of circulatory function becomes irreversible. Where if we tried to start it, if we tried to resuscitate the patient, we wouldn't be able to. What Burnett says is, well, after just a couple of minutes, we know that the heart isn't going to start again on its own. And since we've already decided that we're not going to try to resuscitate, we can assume at that point that it's as good as being irreversible. Since we've decided that we're not going to try to resuscitate and the heart's not going to start on its own. So he says after 2 minutes, it's as good as reversible. Now, I think there's some problems with this. I think, after a minute or two, we can definitely say that the patient is dying, but they aren't out there yet where they're dead. And I think this mistakes a prognosis, that is, that the patient is going to die, with a diagnosis which is that they are dead. And let me give you just a little thought experiment to really drive this home. Consider a DCD donor who has been declared dead after 2 minutes of pulselessness. Now, we usually do this with the family at the bedside, and imagine that in a moment of grief, his wife insists that he be resuscitated. Now, putting aside whether or not the physician should do this, let's just say that they do, and let's say that they are successful, which they quite likely would be. What can we say but that he's been raised from the dead? He's been declared dead, resuscitated successfully, and now he's alive again. If there's one thing that I think we could all agree on, it's that death is irreversible. I mean, outside of miracles, people do not come back from being dead. And yet, under these protocols, they are routinely placed in that position. So let me summarize up to this point. Either our analysis of both brain death and DCD are wrong, or we are already routinely removing organs from patients who are not dead. And in so doing, we are causing their death. The paradox here is that we need living organs from dead patients. And so we have contrived implausible definitions of death so that we can obtain living organs without appearing to violate the dead donor rule. So this is a problem. So what are we going to do about it? Well, I'd like to ask the question, does it really matter whether the donors are dead? And this is how I will complete the conversation with you here. So here's our book, and here's where we try to make the argument. And so here's what we normally do. So we've got a patient who has a lethal brain injury and a request to donate organs. So what we do is we put them through an orchestrated death in the operating room, and then we procure their organs. And what I'd like you to think about with me is, what does going through this orchestrated death add to the ethics of the matter? Does it really do any ethical work for us that we care about? Well, the reason we don't do it is very simply because there is this view that doctors must not kill. This was a famous editorial that was published in the Journal of the American Medical Association a number of years ago, written by top ethicists in our country. Doctors must not kill. So that's why it's not okay for us to bypass the orchestrated death. Well, let's ask, do doctors cause death? And I'd like to ask you a question. I'm going to ask you to raise your hands in a moment. Imagine removing a ventilator from a patient in a permanent vegetative state in accord with the patient's advance directive and at the family's request. Okay? Think about that. Ask yourself, would this be an ethical thing to do? So how many of you would think that this would be an ethical thing to do? Say it's 90+%. Okay, now let me ask you. In doing so, would I be causing the patient's death? How many of you would say that? Yes. Yes, I would be causing the patient's death. Okay, I think we dropped to about half. Okay. I expected that. We don't like to think that we are causing death. But now I'm going to challenge you. This patient could have survived for months or years but for your action. The but-for test is the general legal standard of causation. But for you withdrawing the ventilator, this patient would not have died. This fits with common sense understandings of causation. So I've got a car running over here. But for my turning the key to the off position, that car is going to continue running. We've got the light switch over here. But for my moving that light switch down, the lights are going to keep lighting. But for your taking that breathing tube out of that patient would keep living. This is how we, in a common sense way, think about causation. You and me are causing the death of the patient when we take them off the ventilator. Now, it's not to say it's not the only cause. There's often links. So imagine somebody comes in to the ICU after a motor vehicle accident and ultimately dies, but for the motor vehicle accident, they wouldn't have died. They were getting better, but for they ended up having a very severe infection from a catheter, they wouldn't have died. They got worse. And but for my withdrawal of mechanical ventilation, they wouldn't have died. These are all causal links in the chain, but all of them are causal, including the last one. We in the ICU will often use this euphemism that we allowed the patient to die. But in fact, I would say that compellingly, we caused the patients to die. Doctors cause death when they withdraw the ventilator. The point I'm trying to make here is that doctors often engage in death-causing acts. And in fact, that's the way the majority of patients now die in ICUs. 60 to 90% of our deaths in ICUs, pediatric and adult, are planned, they're orchestrated, and they happen with us removing the patient from the ventilator. And when this happens, we use the euphemism, we allowed the patient to die. None of us like to say what I think is the truth, which is that in doing so, we were causing the patient's death. Whether these death-causing acts are right or wrong depends on a number of factors. The patient's condition and prognosis, for example. If I remove the ventilator from somebody who otherwise would be expected to do well and live, that's wrong. I shouldn't have done that. the socially sanctioned role of physicians to cause death. It matters if it's me doing it and not some angry enemy of the patient who sneaks into the ICU and does it, right? It's okay if I do it, it's not okay if the enemy does it. Most importantly is the consent of the patient or surrogate. It's not okay if I don't have that consent. Let me give you just a little historical perspective on how we got here. This is the famous Karen Ann Quinlan case in New Jersey in 1976. It was a young woman who was in a persistent vegetative state, and her family said, you know, she's never going to wake up. We want to withdraw the ventilator. The doctors refused. Why? Because to take her off the ventilator would be against medical ethics. It would be causing her death. The court actually agreed. The court said, yes, in taking her off the ventilator, you would be causing her death. But that doesn't matter. You have to do it because her privacy and liberty interests are more important. We don't care if you think you're causing her death. You have to do it. Medical profession uncomfortable with this concept. And so we invented the euphemism to relieve this tension. We said, well, we're not going to call it causing death. We're going to change the name. We're going to say that we're allowing her to die, despite what I think are the objective facts of the matter. So Frank Miller and I have a different approach. I'd like you to consider patients who are dependent upon life support. They've refused the continuation of that life support. They've consented to organ donation. If it is ethical for doctors to cause their death by removing life support, then is it ethical for doctors to cause their death by removing vital organs as a part of the process? If the first is acceptable, why not the second? Why not the second? So I'm saying that we ought to be able to use that more efficient, and I'll say why in a moment, the lower pathway, that orchestrating death does not add anything to what makes this ethical. So in summary, under this approach, I'd like to say that there's no patient who would die who would not otherwise die. These patients have already had a decision made to withdraw life support. They are going to die. The question is, 30 minutes from now, are they going to be dead with their organs, or 30 minutes from now, are they going to be dead having been allowed to donate their organs? The wishes of patients to be organ donors could be honored more fully, and more lives would be saved by organ donation. Now, why do I say that? Because at least under the DCD pathway, the organs, you know, having gone for several minutes without blood flow, are not in that good a shape. And in most cases, the only ones that we can transplant are the kidneys. Whereas under the proposal that Frank and I have been discussing, all of the organs, heart, lung, liver, kidneys, et cetera, would be transplantable and would be in the best shape possible, which is, after all, what we want when we want to be an organ donor, right? I mean, if heaven forbid, I would be in that situation, I would like to donate my organs, number one, and I would like to donate the most I could and in the best possible shape that I could. Furthermore, by shifting the way that we think about the ethics of this, the ethics of organ donation would not rest upon untenable definitions of death. Now, I just have to respond because so often in the question and answer period, somebody will say, well, that proposal is so utilitarian. Now, first of all, I don't think that there's anything wrong with something being utilitarian, especially here in Australia. You guys are famous utilitarians. But nevertheless, it's taken to be a criticism. So I just want to say, utilitarian strategies tend to subjugate individual rights and liberties to the common good. That's sort of why people object to them. Well, basing donation upon someone with a devastating neurological injury and the request of the patient or family to donate, that doesn't sound very utilitarian. But claiming to respect the dead donor rule while bending the definition of death to facilitate organ procurement, that really sounds like the utilitarian strategy. So I think it's those who disagree with me that have to defend themselves against claims of being utilitarian. Winding down now, can we really abandon the dead donor rule? Are we willing or possible to give that up? The big worry, of course, is that we assume that the dead donor rule is an inviolable principle of organ donation. So we worry that if we acknowledge the truth about how death is defined for organ donation, we will destroy the public's trust in the transplantation progress, and this will lead to the unnecessary death of many patients. Indeed, I've had people, and in good faith, after hearing a talk like this, saying, giving these talks is irresponsible. It's irresponsible to cast doubt upon the way that death is being diagnosed. Because if people know about this, they're not going to want to donate their organs. And you are going to be responsible for the death of very many people. And that's a hard thing to hear, and I take this very seriously. Maybe we can talk about it more in the discussion. But ultimately, I believe that truth is going to get us to a better place than perpetuating these fictions. First of all, I'd like to question how much the public really cares about the dead donor rule. I'll share two anecdotes with you. The first had to do with a little girl that I took care of in my intensive care unit, and her story was actually written up in the New York Times Magazine, and so that's where these quotes come from. This is a picture of her parents. It was a very tragic case. She was a little 8-year-old girl who was out with her mother snowblowing, and her parka got caught up in the snowblower, and she ended up being strangled. And her mother couldn't free her from the snowblower. And she came into our intensive care unit, and we did everything we could to resuscitate her, but she ended up having very, very severe brain damage. And her parents wanted to donate her organs. Now, remember I told you that the way we do this is we go down to the operating room, we withdraw life support, and we wait for the heart to stop. But it has to stop within 60 minutes. And hers did not. And so she couldn't be a donor, and so she came back to the intensive care unit, and she died about 12 hours later. And her parents experienced this as sort of a double loss. They had lost their child, of course, and then there was this hope to be able to donate her organs, and now this had been taken away from her too. So Darshak Sanghavi was the reporter here, and he was interviewing her father, Paul, and he says, Paul has some difficulty understanding why, if Jaden was going to die anyway, she could not have been put under general anesthesia, undergone surgery to donate her organs, and then be declared dead. Couldn't understand. Why couldn't you do this? And Darshak Sanghavi explained, well, we couldn't do it because there's this thing called the dead donor rule. Can't take her organs until she's been declared dead. And her father responded, yeah, but I understand, but there was no chance at all that our daughter was going to survive. I can follow the ethicist's argument, but it seems totally ludicrous. Now, an N of 1, you know, I'm not saying that this is any big survey, but it's the experience of one person who's gone through it and said, I don't quite get the importance of this dead donor rule thing. Let me give you one other example. This was a case at the University of Pittsburgh late last year, and this is one now of a number that are arising in the United States. 52-year-old man who had suffered a devastating stroke, and after several months, his family agreed to withdraw life support. This was somebody who had said over and over in his life, you know, if it ever happens, I want to be an organ donor. Problem was he wasn't brain dead, and also they were pretty clear that he wasn't going to die within this 60-minute window, so he was not a candidate for DCD. The family said, no, there's got to be a way that we can donate his organs. He really wanted to donate his organs. Isn't there some way we can donate his organs? And they're, no. So finally the family said, we know how we can donate his organs. He can be a living donor. So with living donors, you know, now if you wanted to give a kidney to your wife or your child, you go to the operating room and they take a kidney and then you live. Right? So they said, well, let's use this model. He really wanted to be a donor. Let's take him to the operating room. Let's take a kidney, maybe even both, maybe even a part of his liver. Okay? It's not going to kill him. It's not going to kill him. And then we'll bring him back to the intensive care unit. He'll recover from surgery, and then we'll withdraw life support and let him die. Okay? Pretty creative. Pretty creative. So this went to the hospital's ethics committee. This is University of Pittsburgh. This is not some tiny little medical center. And the hospital administration. Everybody said, it's fine. Sounds like a reasonable plan. It's compatible with the patient's wishes. There's no harm to the patient. And it conforms to the dead donor rule. So they were all set to go forward with this. But the transplant was denied. The surgeons wouldn't do it. And here's the reason, you can understand, is that for living donation, again, you're giving your kidney to your wife or your child, they want to hear directly from you that you consent. And that makes good sense, you know, in 99% of cases. It good sense that you should directly consent. Obviously, in this case, he couldn't consent. He was unconscious. But there was plenty of evidence that this was something that he would have wanted to do. So this really felt like a technicality. And this family feels aggrieved that he was not able to donate his organs. Life support was withdrawn. He died a couple of days later. But they are, you know, they've given permission to use his name. They're on the talk show circuit. Why couldn't my husband, his wife, is saying, why couldn't he donate his organs? Granted, what they had constructed here was sort of an end around to the dead donor rule, but nevertheless, something that they wanted to do, something that seems completely ethical, at least to me, was denied to them. And so in closing, let me see if I'm going to make sort of an historical analogy that maybe we can tie this into some issues in human rights. If you go back to the 1970s, the big debate was that patients wanted the right to refuse unwanted medical treatment, and physicians were refusing. Why were they refusing? Because they did not want to have an active role in the dying process. They didn't want to be the ones taking out those endotracheal tubes. And our courts got involved and said, nope, you have to do it. 1990s, physician-assisted dying. Patients want more control over the dying process. All of organized medicine resists this. We do not want to have an active role in the dying process. And so states have adopted legislation. Now I have four states where physician-assisted dying is now legal. Physicians don't have to do it. No one's compelled to do it, but it is an option. And now in the 2000s, around organ donation, there are some patients who want to donate outside the paradigm of the dead donor rule in ways that feel entirely ethical. The parents of the young girl I described to you, the wife of the man in Pittsburgh. Again, physicians are resisting, rejecting an active role in the dying process. And I feel that the medical profession gets dragged along by this, with really the public pushing it. And so in closing, let me just make a comment. Some of you might be familiar with the work of Kuhn around the structure of scientific revolutions and the way that paradigms change. And he said that dominant scientific paradigms can withstand and absorb anomalies and conflicting data up to a certain critical threshold. But beyond that point, they are vulnerable to a wholesale revision that shifts the entire foundation of thought. And so I'm asking tonight, have the current concepts of brain death or circulatory death reached this tipping point? In other words, we got this whole structure around brain death, circulatory death, and the dead donor rule. And it seems to at least be teetering on its foundations, if not actually falling down. Have we reached the point where we need to come up with a different paradigm for thinking about the role of death in organ donation? And if so, we believe that a more open and transparent understanding of the ethics of organ donation is to be welcomed and not feared. And so with that, I'm going to stop. Thank you very much.
Thank you very much, Professor Truog. A compelling case to rethink, I guess, some of the established things we take for granted in that field. I won't say more because my colleague will. I want to introduce Dr. Andrew McGee now. And it's appropriate that Andrew respond. It was his work and his engagement with Professor Truog and Dr. Franklin Miller on this body of work which has brought Professor Truog to the Health Law Research Centre. So Andrew is in the Health Law Research Centre and has joined us in 2010, and law was his second career. He has a PhD in philosophy from Essex and did postdoctoral research fellowship in University College Dublin. He practiced Lord Allen's and has also worked for the Office of Queensland Parliamentary Counsel and has published in the best international leading journals in medical ethics, medical law, on the areas of end-of-life decision-making, organ donation, withdrawing, withholding, treatment, palliative care, and so on. So I invite Dr. Andrew McGee to respond.
Thanks, Ben, and thanks, Robert, for a very engaging talk. Just got to work out now how I get my slides up. There we go. All right, so what I want to do for my talk is just explore a little bit further some of the ethical issues that are raised by Robert's proposals, and just to have a look at maybe some of the obstacles that might be actually leading physicians to resist what seem to be quite straightforwardly ethical proposals, and just to perhaps examine a couple of those and to see how good they are as objections. I'm not going to disagree myself. I want to make that very, very clear. I find Professor Truog's views on this particular issue to be compelling. I do disagree on a couple of issues in terms of the route by which he gets there, particularly the causation issue, so I will go into that. And some of the other grounds of unease, which is really what I want to explore tonight, are, well, some of them are better than others, is what I'm really going to be claiming. I sometimes like to look at what's on the left-hand side. Is that okay? Are people struggling to see the slides? You are? Okay, hang on a second. How does one get to F5? Okay. So there are three potential sources of unease that these proposals might actually give rise to. Can we justifiably assert that procuring organs from these donors with prior consent, or at least consent from a surrogate, doesn't harm the donor? Could the practice give rise to societal harms, such as the devaluation of human life or the devaluation of the lives of very severely incapacitated or disabled people? And would the practice be compatible with the fiduciary nature of a doctor's obligations towards the patient if organs are procured while the patient is alive for the benefit of others? I'm not going to be able to look at that last concern. I'm only going to focus on the first two. As I understand Robert's argument, it's this. A, we can procure vital organs from so-called brain-dead patients and DCD patients, even though they're not dead, and even if this causes their death. B, this doesn't harm the donor because the donor, one, is having life-sustaining treatment withdrawn in any case, and so is to be allowed to die. Two, has consented previously to the donation. And three, will feel no pain or discomfort from the donation of the organs because the donor is unconscious or anaesthetic can be given. And the fourth point as well that Robert has made with Franklin Miller is that the patient at this stage has no interests that can be set back. All right, so let's have a look at the first major ground, harm to the patient, of unease we might feel. The concern may stem from the following considerations. Could the decision to withdraw life-sustaining treatment be contaminated by organ donation considerations? The answer to that would be that the end-of-life team looking after the withdrawal can be entirely separate from the transplant team. But can we be sure that in at least some cases, donation considerations won't enter into the decision to withdraw life-sustaining treatment, compromising those decisions? Can we adequately seal off the withdrawal decision from the donation decision? Robert suggests an ethics consultation committee as a way around this. It doesn't seem, in all fairness, to be an insurmountable problem. I don't think it's a strong argument against the proposals. The second consideration is if organ procurement causes the patient's death, is not the patient requesting the active termination of their life? And is not the doctor, therefore, engaged in what you might call organ donation euthanasia? Well, again, we're just dealing with the harm point at this point. Robert says this isn't going to harm the patient because a decision has already been taken to allow them to die, and no patient will die from organ donation who would not otherwise have died from the withdrawal of life-sustaining treatment. It is hard to disagree with that. We tend to imagine organ procurement as brutal and invasive. We find the thought of dismantling the patient as they are dying unsettling. And this is probably the source of our unease, or at least one source of our unease. But the patient will be unconscious or will be anaesthetized and has given fully informed consent. So this particular issue about whether it harms the patient doesn't really seem to be the ground of our major concern. Rather, it's really about the harm to society. Another issue, will the patient have consented in every case? Bob's presentation focused primarily on those cases where consent can be given by the patient. But what about the use of organs from dying babies? What about surrogacy consent in cases of adult patients whose views on organ donation are not known? These cases can't really be described, for example, as respecting the precedent autonomy of the patient. Let's now turn, though, to some of the social harm issues. The unease here is that allowing the procurement of organs before the withdrawal of life-sustaining treatment, and so causing death, at least in some cases, is killing the patient to save others, and so crosses the Rubicon between allowing patients to die and killing them. And this, it might be said, devalues human life and suggests that the lives of very severely disabled people are not of value. In reply, Robert says we're already causing the death of patients whenever we withdraw life-sustaining treatment. Turning off a ventilator is like turning off ignition in a car or switching off a light. Although Robert prefers not to use the word killing, it should be noted that killing at law is defined simply as causing death. And the law does distinguish between killing and letting die, and regards the withdrawal of LST, life-sustaining treatment, as letting die rather than killing. So by rejecting the claim that withdrawal merely lets the patient die, Robert can argue that our concerns about organ procurement causing death are misplaced, because we're already routinely permitting doctors to cause death by allowing them to withdraw LST. But our unease here might stem from a feeling of being slightly cheated by this argument, or at least that's what I want to suggest. With life-sustaining treatment, we place significance on the fact that the treatment has been provided to begin with, and that we're merely stopping that life-prolonging treatment. The flip side of stopping the treatment when we do is that we started it and prolonged life in the first place. So withdrawal of life-sustaining treatment, at least in the law, is regarded as the reverse of initiating it, as the cancellation of the original decision. And the net effect is what is looked at. It's the net effect, which is tantamount, according to the law, as non-intervention. And there's a paper there by Jeff McMahon who makes that point himself. So traditional medical ethics and the law therefore regard withdrawal as allowing the resumption of the dying process that was originally halted in its tracks when the life-sustaining treatment was provided. And so it's in this sense that it regards withdrawal as allowing to die rather than as killing. It's also worth noting here, though, that not every withdrawal fits the ignition switch analogy. Dialysis, for example, is provided periodically, so withdrawal of dialysis can simply take place by it's not being provided the next time you're due to go on it. Artificial nutrition and hydration is provided through a tube, but again, that's provided periodically, and in the famous case of Bland, it was held that the tube could actually be left in place, and simply we refrain from providing the treatment the next time it's due. So we must be careful that we don't sort of get sidetracked by the fact that acts of flipping switches and that kind of thing or withdrawing tubes can sometimes be involved here, because it might actually mask the real nature of what is being done, which is the patient is being allowed to die. The third point that's worth making, and this is a point that Robert and Frank Miller have themselves conceded in their book, they claim that withholding life-sustaining treatment does not cause death. So if you simply stand by and you don't intervene in any way and you allow a patient to die, then provided you don't have a duty to intervene, you do not cause death. And that might be the case even if the patient could go on to live for quite some time if you did provide the life-sustaining measures. So the argument then would be, well, if withholding doesn't cause death for that reason, then surely providing the treatment and then withdrawing it down the track can't cause death either in that real net sense that I described earlier. Look, objections can be made to this analysis. We discussed some this morning. Conveniently for me, I can't go into those here. In my view, these objections can probably be answered. But what I want to say is this. Perhaps in appealing to this particular ground to support Robert's case, it might actually undermine that case slightly. Really, it could be needlessly distracting, this idea that we're causing death all the time, right? Because people will feel uneasy about that claim. It is different from giving someone a lethal injection, for example. The case, I think Robert's case could be made without relying on this particular argument about withdrawal not being able to be seen as letting die. So I think it's needlessly distracting, that particular issue. Could the proposal undermine the value we afford to human life and the value of the lives of the very severely disabled? It's not easy here to express our unease in a clear way. The fact that organs will only be procured from patients who will in any case die from the withdrawal of LST suggests that this worry is indeed misplaced. Also, the proposal is clearly aimed at saving lives, the lives of the donees. But one way of expressing the concern here, and I want to emphasise it's not necessarily a genuine concern, I'm just trying to identify a prima facie concern, is this. The boundary between life and death is so important to us because we have a clear view of where our obligations begin and end. We know our obligations are to do everything in the best interest of our patient, don't cease until the patient has died. We also know that our obligations change once the patient has died. Once we start to contemplate practices towards a patient before death that we don't normally contemplate starting until after death, the risk of confusion can be a real one. We may end up having to claim, for instance, that brain-dead patients and DCD donors are no longer persons and so don't have the right to life, which invites controversy, even if it might be true, right? It invites controversy. The pressure, of course, to endorse that argument in particular arises where autonomy arguments and consent doesn't apply, so the infant cases or the wishes not being known cases. Julian Savulescu has claimed a permanently unconscious patient is not a being capable of having interests, and Walter Sinnott Armstrong and Franklin Miller have said a permanently and totally disabled person can't be wronged from being killed or by being killed. These claims are not likely to be attractive to the parliamentarians charged with enacting the required laws, mainly because of the perception it might create about the value of the lives of the severely disabled, even if the paper itself restricts those arguments just to brain-dead people or DCD people. The perception that this might devalue life is a significant source of unease. And this point about perception is actually an important one. For the point is that perception remains important even if the reality is actually otherwise than it's perceived to be. The very fact that we might have to work hard to prevent misperception or misunderstanding might itself be a ground for caution in adopting these proposals. The well-known phrase, perception is reality, in a sense captures this problem. What I take the phrase to mean is that the way in which something is framed or how it comes across is as important as the reality behind it. It may be better simply to say waiting for death from withdrawal rather than from organ procurement is neither a benefit nor a detriment to the patient, and leave it there, not adopt more metaphysical views about interests and rights and so on. Look, I want to close now by just making a point of qualification. This perception point extends no further than that claim. I don't think it's decisive. It may be important enough to proceed regardless of that perception claim. One point that's made by Robert as well is that in countries like Belgium, some of these proposals are already being practiced. We can therefore do empirical work to see if the concerns expressed by this ground of unease really are justified. And that work needs to be done. It's not enough just to express what seems like a prima facie objection, a prima facie plausible fear or concern, and leave the analysis there. We need to press on and find out if the concern really has any basis to it. So really, in articulating that perception point, I just wanted to try and really pinpoint exactly what the source of concern might be, what the resistance might be. That's all. I'm going to leave it there. I've spoken for long enough.